everyone. I'm Dr. Shilpa Gupta, medical oncologist at the Cleveland Clinic, and I'm really honored to be joined by extraordinary panelists here, Dr. Sridhar, Dr. Garmezy, and Dr. Tawagi. Could you introduce yourselves, please?
Sure. I'm Dr. Kala Sridhar. I'm a medical oncologist at the Princess Margaret Cancer Centre in Toronto, and I treat GU cancers.
I'm Ben Garmezy. I'm a GU medical oncologist here in Nashville, Tennessee. I'm part of Sarah Cannon Research Institute, and I also practice here in Nashville at SCRI Oncology Partners.
I'm Karine Tawagi. I'm a genitourinary medical oncologist at the University of Illinois in Chicago, and happy to be here today.
Thank you. So a lot of excitement is going on in the bladder cancer space, and if you were at ESMO, you saw a lot of new data there. So I would love to hear from you. What was the most exciting thing you thought was in bladder at ESMO, Kala?
Sure. I mean, I think the NIAGARA study was probably the most interesting that we saw there. Part of the reason is just the fact that we were able to do a phase 3 study in the neoadjuvant space, which I think represents a major step forwards in this disease. Of course, we've been challenged with giving neoadjuvant chemotherapy, just standard platinum-based chemo. So to have a trial in this setting, I think is really exciting and interesting, and I think that was probably one of the highlights for me.
Yeah, 1,000-patient study to read out with overall survival benefit at the first analysis is really impressive. So just to pick your brains a little bit on the NIAGARA study, what did you think of the PCR rates with the combination versus the GemCis control arm, which was 27%, and the PCR rates were not that high with the addition of immunotherapy, but do you think that really matters with immunotherapy, or is it something else we should be looking at?
Yeah, I think it's an important consideration. I think it's what we've been relying on for a long time, looking at PCR rates. You have to keep in mind that the group of patients who were enrolled were perhaps a little bit more aggressive patients. They did cap the T2 patients, so there were a bit more T3 patients. I think it's a composite. I think we have to look at both short-term endpoints like PCR, which we've looked at for a long time, but also some of the longer-term endpoints like EFS and OS.
Yeah, and I thought it was interesting that in this, they also allowed N1 patients, which typically get excluded from these trials. So Ben, I would like to ask you, what did you think of the creatinine clearance cutoff? You know, it was a bold step to make it 40 instead of the historic 60, and Dr. Sridhar has actually proposed that, 60 is not the modern day cutoff anymore, and we all are comfortable using cisplatin at around 50. So what did you think of this cutoff, and do you think it's happening in the real world with your experience in the community oncology?
I would say, I think it's great. One, I think we can debate whether it should be 40 or 45. Sometimes when you get in the low 40s, in my personal practice, it gets tough and patients' creatinine clearance starts to drop into their 30s pretty quickly, and you start to get nervous, especially in the neoadjuvant setting, where you don't know what their creatinine clearance is going to be after surgery as well, right? So something to keep in mind. But we clearly need to lower the threshold under 60. That has not gotten taken up widespread into the community. Community docs who are GU specialists have brought it down to about 50 from conversations that I've had, and I think it's now time to bring it down to lower than that. I've been bringing it down to 45. Maybe I should be bringing it down to 40 now after this great data set. It's time to reevaluate our own clinical practice. But split dose cisplatin, if anything, is easier, right? I mean, they're coming in day 8 anyways. You can give it on day 1, day 2, but you can give it day 1, day 8. So it's very easy to do in a community oncology setting. We just need to convince, and that means changing algorithms. It means changing the way pathways work with various community oncology settings so that creatinine clearance of 60 is no longer on that front web page, so that you can know that cisplatin is an option. And then I think we can take this data set and run with it, and then how do we apply it in other settings as well? I think it's interesting.
Yeah, and I think, in our other trials, we would deem such patients cisplatin ineligible. So I think we're moving away from these historic data. So Karine, what did you think of the 1-year EFS with the GemCis Durva, which was 70%, and 2-year was around 67% with the historic cisplatin-based therapies? Do you think this is really a big step forward, or would you be interested in knowing how many patients in the control arm eventually got immunotherapy, and how does that impact your decision?
Yeah, absolutely. I think that's a great point. At the time that the trial was conducted, we didn't have adjuvant immunotherapy as our standard of care post-cystectomy, so we don't know the answer to that specifically. We also don't know if all of the patients on the trial necessarily need that adjuvant component of the therapy. But I think it's really exciting to have this data. It's exciting that there is a significant overall survival. We don't have overall survival data for any of the adjuvant trials for which we have approvals right now. So I think overall it's really exciting that you can have that overall survival benefit when you're having that discussion with patients, and also it will help for regulatory approval, I think, to have that data.
Yeah, it's really important, and the FDA is coming down hard on the neoadjuvant versus adjuvant part now, like in lung cancer trials. They're mandating now, moving forward, we should have a clear-cut idea of what the benefit of adjuvant versus neoadjuvant is. So that's really